Hello, I'm Dr. Daniel Griffin.
And I'm Dixon DePommier.
And today we're going to be discussing headache disorders. This is a pretty broad one. I know I mentioned that we'll be discussing tension headaches, migraine headaches, but you said, aren't there others?
Yes, are there others?
I think the simple answer is yes.
Absolutely.
And I wanted to give people a context of how significant a problem this is.
Right.
Often we think when we go areas to practice that we're going to be treating certain diseases, but I want to point out that primary headache disorders are one of the top 10 causes for, I'm going to introduce new terminology, disability adjusted life years.
There you go.
And so something called DALYs, D-A-L-Y-S, is a way of assessing the impact of a disease has on people's ability to basically live life, work a job, go to school.
That's right.
And headaches are one of the top 10. And what makes this more significant as a global health issue is the peak incidence is in persons in the 20 to 50 years of age, so right when they're trying to provide for their family.
Right.
So this is a devastating, I'll say, major issue, not only for the suffering, but for the impact on the family.
Yeah.
So let's talk a little bit. Let's try to list our headaches. So I mentioned tension type headaches, okay?
Okay.
And I'm gonna put under that dehydration, which often present as a tension type of headache, so our tension and dehydration headaches.
Yep.
We distinguish those from our vascular or migraine headaches.
Okay.
And then I'm going to say we have a whole bunch of what we'll call secondary headaches. And this might be a headache due to hypertension. This might be a headache due to infection.
Correct.
This might be a headache following trauma.
Exactly.
So there's a lot of, again, we're going to be making the distinction, as we always do, between primary headache disorders and secondary headache disorders, where we want to be focused on that secondary cause.
Right.
And if it's an infection with fever and associated issues, we don't want to be just focused on the symptoms and symptom control. We want to be focused on treating the primary issue.
Exactly.
Now let's make a little bit more of the distinction between vascular and non-vascular.
Okay.
Okay. So, and actually, are you a headache sufferer yourself, Dixon?
No.
Have you ever had a headache?
Of course.
Okay. No, I would
I'm
be
a human, so I think that I don't know a single human that I've ever talked with, at least on a superficial level, that has not had a headache at some time in their life. And I can think of several reasons for headaches. One is trauma. Mm-hmm. Little kids, they run around lots of times and then they fall down and they bang their head on the sidewalk or on a pipe that they didn't see while they were running through the playground or something like that. And I can recall several that I've had as a child, which was as the result of getting into a rock fight.
a rock fight.
Rock fight.
This involves throwing rocks at
Oh,
each
yes.
other?
Oh, absolutely.
This sounds like a very bad idea.
It was a horrible idea. In fact, I was at the short end of that stick, so to speak.
Okay.
And I remember looking up and catching a rock right on the brow of my left eye. And not knowing that I was actually hurt, I continued to engage. And then I looked down at my white sneakers, and one of them was covered with blood.
Okay.
And that happened as the result of this trauma. Now, a quarter of an inch lower, it might have poked my eye out, for all I know. It was a stupid thing.
And that's when the fun is all over. We have an expression, it's all fun and games until someone gets an eye poked out.
I had to walk home like that, and I had to present myself to my mother, and I had blood all the way down the left side of my body. And I'm sure she was pleased to see me.
I'm sure she was not.
What were you? You know, that sort of thing.
No, that's an interesting question, because I was under the impression that everyone at some time in their life has had a headache. But I have, my children suffer from migraines, so vascular headaches.
Yeah.
And one of my daughters, the headaches had gotten so severe that she was missing quite a bit of school, required hospitalization, sort of give people a context of how severe headaches can become.
Absolutely.
And when we went to speak to the principal of the school, her comment was, you know, I've never had a headache, but my sister-in-law gets headaches.
Never? She's never had a headache?
And it was very, very enlightening. And I think that one of the realizations is as we point out, this is a huge impact on people's lives. And there are people who I think, and clinicians, who may underestimate the significance of some of the headache disorders. And so
I would agree.
One of the things I think it's important to hopefully get across is that headache disorders can be incredibly disabling. Migraines are not just headaches, but are really systemic illnesses that could have associated nausea, vomiting, throbbing. There's even intestinal forms of the migraines where the pain might be abdominal in focus.
Yep.
So I think it's really important for us to use our pain scale again and to get a sense when someone says, oh, I have a headache, it may be mild, distracting, end of the day, or it may be to the point where the person is completely incapacitated.
Right.
And unfortunately, millions and millions of people that we'll encounter are having headaches to the point where and migraines to the point where they are completely debilitated.
Wow.
So let's focus a little bit on making sure we move the non-primary headache disorders off the table.
Okay.
So we talked a little bit about dehydration as a trigger.
Yep.
And that is a problem throughout the world.
It is.
And it's actually one of the first things we try to assess when someone comes in. And we have a whole section where we talk about dehydration and diarrhea, where we talk about how to better assess fluid status and hydration status.
That's right.
The next, you mentioned trauma.
Yeah.
Not only can you have head pain from getting hit in the head like a rock if you're engaged in an odd activity that you described, but after someone's had significant head trauma, there can be a chronic headache disorder that is incredibly difficult to treat.
You got it.
So we talk about post-traumatic,
Yep.
not only cognitive impacts, but post-traumatic headache syndromes.
Sure. Are you going to count sinus headaches in this, or just brain-related headaches?
I'd say that's another one of the ones we want to push out as a secondary disorder.
Right.
If the person has pain that's focused around the sinuses.
Or up over here?
So frontal sinuses.
Okay.
Or ethmoid or maxillary sinuses.
Okay.
Yeah.
Okay.
So you want to always be doing your assessment. Is the headache a primary issue?
Right.
Or is the headache secondary to something
Right,
else?
right.
Once we've focused ourselves on a primary headache disorder,
Sure.
then we want to be sort of making our differential between, we'll say, a tension or non-vascular type headache and our vascular or migraine type headache. Because this is going to affect our treatment. We're going to approach these somewhat differently.
A lot of people also take the worst case scenario when they develop headaches and say, oh, I must have a brain tumor. What would you say to that?
So it's very uncommon for headache to be presenting as a brain tumor. I say very uncommon, but there are certain hints as well.
Yeah.
I want to be careful when I say age because we see brain tumors in younger individuals.
Sure.
One of the issues might be that the person notices that when I lean forward, the headache is worse.
Oh.
That can be a little bit of a challenge. It's a challenge with regard to resource utilization. In areas that are resource rich, a lot of individuals at some point in their life, if they have a headache disorder, will have imaging.
Sure.
To rule out, we'll say, is non-benign etiologies.
Right.
But you've got to ask yourself in your different practice, does that make sense? Everyone with migraines or tension type headaches, does everyone need a CAT scan? Does everyone need an MRI? The interesting thing is maybe in the areas without the resources, they're more important to do these. Because I think there's some parasitic diseases,
there are,
right?
and we'll get to those, I'm sure of that. But neurocysticercosis jumps to the top of my list for parasitic infections that can lead to headaches, or at least signs and symptoms related to space-filling lesions.
Yes.
Which may not be a headache, but which frightens the hell out of somebody because they can see perfectly well, and the next thing you know, they can't see out of their right eye, or their left arm doesn't work anymore, or they're stumbling when they used to be as a track star. Mm-hmm. And this is a terrible turn in someone's life that up to that point was normal. And so that's the sort of thing that we're talking about.
So I think when we're making the diagnosis, not only do we want to get a really good history, but you want to do a really careful exam so that after you've said, okay, no fever, no weight loss,
Right.
none of the, your blood pressure is not 210 over something.
Yeah.
Once you've ruled out secondary causes or feel like you've done that from your symptoms, from your
Yes.
history of present illness,
Yes.
you really want to do a careful neurological exam on all your patients.
Absolutely.
To make sure that there isn't any hand weakness or
Sure.
focal neurological deficits,
That's right, that's
suggesting that this is not just a benign or I
Exactly.
hate to use the term benign, but a primary
What
headache
do you do with
syndrome.
someone who comes into your care and says, I don't get migraine headaches, but what I do get are these flashing, pulsating, sort of, it look like lightning strikes, but they're colored. They're almost like the spectrum of the rainbow, for instance. And they start out small and you're going to get one, and then all of a sudden it starts to creep in and it takes over most of your visual acuity,
Yeah.
and then it retreats, and the next thing you know, you feel great. Wow, that was terrific. What was that? And that the people they describe that as an aura,
Yeah,
but it's not a headache.
Yeah, when we break down the migraines, we'll do this. Actually, we'll do it right now. Let's just jump right into this.
Please.
Is we talk about migraines with auras, migraines without auras, and then as you described, sometimes people have auras without headache,
That's me.
right? And so people can get those, and some people are very disturbed by these.
I
Some
was to begin
people
with.
are sounds like entertained.
Oh, and then they become a light show. They're fantastic, and they're triggered by interesting things like you look accidentally at the sun, or you look at a bright light or something like this, and you turn away, and then that triggers the aura. Is that also a trigger for migraines?
So, talking about migraines, so we've made this distinction with and without aura,
Yep.
but I don't know if it's that important in treatment, in all honesty.
Okay.
But when we are thinking about treatment, one of the first things we like to do is look for precipitants, and that can be incredibly challenging. Dehydration can be an issue. Varying caffeine intake can be a trigger for migraines.
Right.
Certain foods, people keep food diaries, and sort of we get mixed
Really?
messages on how
Yeah.
well that works. Some people swear by it, other people think the evidence is a little thin on that. Sleep deprivation can clearly trigger. So there can be a number of things, and one of the first things we ideally want to do before we get to our medications, our pharmaceuticals, is start looking at what are the potential triggers. Exercise. People who do not enough or not regular exercisers can have increased issues with their migraines.
What about stress?
Stress, either the absence, the end of the stress, or
Right,
during.
exactly right.
Some people have the Friday night migraine. They're
Really?
fine all during the week.
You're kidding.
Excessive sleep. They sleep on a Saturday and then they wake up at 10 because now they have too much sleep.
Oh, dear.
That can trigger a migraine.
Oh my goodness.
So there's a lot of triggers, and it's important to take the time,
Wow.
because time is maybe a little less expensive than our medications in a lot of areas. Take your time and maybe ask the patient to take their time clarifying triggers that can be helpful in preventing the migraines.
Sure.
A lot of the same triggers for migraines are going to trigger our tension headaches.
Ah,
A lot of the tension headaches
Okay.
people will describe at the
Sure.
end of the day.
of course, of course.
And so it can be dehydration,
Yeah.
it can be caffeine, it can be some of the other things that are related.
Right.
So the first thing before you start jumping into our drugs is what are the lifestyle and precipitant modifications that you can do to prevent these. In the same thing, I think it's important, even if people do all these, there's still a large percentage that will still have
Exactly.
the headache. So want to be careful not to blame them. I think
No,
that's
it's-
always an issue.
Are you assuming a genetic origin for migraine?
So I think that there's pretty good evidence that migraines run in families, that there's a genetic component. Tension headaches, very, very common.
Right.
Again, probably seem to cluster. Once we actually get to the point where we want to treat them, let's talk a little bit about how we might treat them.
Right.
And it's a little bit different, maybe. The recommendations have historically been a little bit different. Our tension type headaches, we usually recommend starting with acetaminophen, paracetamol. And a lot of this is the issue that our ibuprofen, our nonsteroidal anti-inflammatories, and aspirin can be associated with more problems in a dehydrated context.
Sure.
So we want to try if we can. Occasionally, a medicine that we discuss in neuropathic pain, sometimes people use amitriptyline. before bed to help with some of our headache syndromes. With migraines, it gets a little more complicated. We break it down into medicines that might be used for acute pain and medications we might use preventatively if the migraines or the vascular headaches start occurring at a very high frequency or an intolerable frequency. So for symptomatic, we might use similar treatments. We might again use our acetaminophen, paracetamol. I'm going to say that tends to be less effective, so we'll often more quickly look at ibuprofen or naproxen or nonsteroidals. And we might also, and this is if we have access to it, we might use the triptan class of medications. Medicines, sumatriptan, and medicines in this class. Unfortunately, I have to say, as wonderful as those medications are, the cost can be prohibitive in a lot of settings.
Sure. Do you have a sense of where the pain is coming from in a migraine headache?
You know, we still don't know. There's a lot of theories. And here it is. We think that there might be an inflammatory component because some of the new biologicals, injective monoclonals, target inflammatory mediators. So it may be an inflammatory issue where we want to target these inflammatory mediators.
Wow.
Yeah. So it's complicated, not well understood. And I will mention that there also are chronic preventive medications. So the amitriptyline I mentioned, sometimes people use that right before bed as a preventive. And sometimes we'll even use our cardiovascular or antihypertensive medicines. So atenolol, which is a beta blocker, can sometimes be used, and some of the other beta blockers.
Are there seasonal variations in the frequency of migraine headaches and people suffering from
So
it?
some people notice that. Some people notice seasonal variations. Some women notice variations relative to their cycles. And so sometimes that can have an impact.
Okay. Wow. And is there a sex difference with acquisition of migraine?
They are more common in women.
They are.
About 8 times more common
8?
in women than men.
That's quite a bit different.
So a pretty significant increase.
It's quite a bit different.
Yeah.
Wow. Wow. Well, I know some of the ancient cures for headaches, but whatever that meant to them at the time, particularly throughout Mesoamerica, it involved actually drilling away the bone in your head to relieve the evil spirits and allow them a portal to leave.
Yeah.
Believe it or not, these people survived after that, and they carried out what seemed to be normal lives, and they aged normally, etc. It's called trephination. And then the Native Americans, the first peoples in this country, discovered that if you eat the leaves of willow, it contains acetylsalicylic acid,
So that could.
which is the basis for aspirin therapy. And by the way, I should mention also that it was the first synthesized drug. Bayer made all of its money synthesizing acetylsalicylic acid, and the first ever synthesized organic compound was urea, because they needed a fertilizer. So here we have farmers and their headache problems could be solved in 2 simple biochemical syntheses, aspirin and urea.
And I like that because that'll bring in closing just our aspirin warning. We'll talk about Rye syndrome. So aspirin has still been utilized throughout the world quite often, but we now recognize that we shouldn't be using it in individuals less than 3 years of age, because of this risk of Rye syndrome,
Which is?
Well, it's a neurological disorder that can develop from the aspirin.
Is
and
it permanent?
It can be devastating and have permanent consequences. So, all right. So to close on that note, thank you for joining us for Headaches, and we look forward to discussing more topics.
That's right. We hope that this series doesn't give you one.
Okay.